Imagine this scene. It's 2:08 a.m. on a Saturday. The emergency room is already at a low hum of chaos. But then the doors burst open. The paramedics are moving fast, wheeling in a gurney, and the report is shouted over the noise of the department. It's short, sharp, and terrifying. Male, 25, gunshot wound to the abdomen.
And that's a scenario that triggers an immediate physiological response in everyone in that room. The ambient noise it fades away, adrenaline spikes, and everyone locks in.
Exactly. And in the movies, this is where the dramatic music swells. The surgeon screams for a scalpel. They, cut the patient open right there in the hallway. Blood goes everywhere.
A total frenzy.
A high-octane frenzy. But the source material we are covering today paints a completely different picture of what actually happens, or at least what should happen, when a penetrating trauma case rolls in.
Right. If the Hollywood version is checkers, the reality is 3D chess played at lightning speed. And, contrary to the movies, the goal isn't always to cut immediately.
That's the part that's so surprising.
Yeah, the goal is often to figure out if you can avoid cutting entirely. It's about discipline, physiology, and strictly following a decision tree that has been, written in blood over decades of trauma care.
That is the part that really blew my mind in these notes. Today, we're doing a deep dive into penetrating abdominal trauma. And before anyone tunes out thinking this is just for med students, stick with us.
Please do.
We've pulled together high-yield clinical guidelines, the kind used for top-tier medical licensing like the USMLE. These aren't just first aid tips. These are the mental models and decision trees that prevent doctors from making fatal mistakes under extreme pressure. It is a masterclass in decision-making.
And the stakes couldn't be higher. I mean, we're talking about injuries where the body's core defense, the abdominal wall has been breached, the fortress has fallen, and how you react in the first 5 minutes, that determines if that patient goes home next week or not.
So we're going to structure this masterclass around 3 pillars, just to keep things organized. First, the mechanism, the physics of why a bullet is so much worse than a knife.
A huge difference.
Second, the algorithm, the strict, almost robotic protocol doctors use to ignore the gore. And third, the decision, that fork in the road between rushing to surgery or taking a, frankly, terrifyingly patient wait-and-watch approach.
That third pillar is where the real art of medicine happens. That's where all the nuance lives.
So let's start at the very beginning, the breach. When we say penetrating abdominal trauma, are we just using fancy words for a cut on the belly?
No, and the distinction is incredibly specific. In the medical world, words have very precise definitions. Penetrating explicitly means an injury where an object has not just cut the skin and not just the muscle, but has breached the abdominal wall and entered the peritoneal cavity.
The peritoneum. We hear that word a lot. Define that for us in, plain English.
Think of the peritoneum as the shrink wrap that holds all your organs together. It's a sealed, sterile sac inside your abdominal cavity.
Like a bag.
Exactly like a sterile bag. If a knife slashes your skin but doesn't poke a hole in that shrink wrap, it's a flesh wound. It might be ugly, it might bleed, but it's not penetrating trauma in the surgical sense.
But the moment that seal is broken,
the whole game changes. Bacteria, air, blood, it can all mix. The sterile environment is compromised, and that's when the clock starts ticking.
And the usual suspects for breaking that seal are pretty obvious. Knives and guns.
Primarily, yes. Stab wounds and gunshot wounds make up the vast majority. You also get impalements, falling onto a fence post, construction accidents with rebar, that sort of visceral injury.
Just horrific.
They're horrific, but they are rarer. The clinical guidelines focus heavily on the difference between the knife and the gun because they require completely different mindsets.
Okay, let's unpack this. To the lay person, and honestly to me before reading this, a hole is a hole. If a piece of metal goes inside my body, it feels like the damage should be relatively similar. But you're saying the type of object dictates the entire medical strategy.
It dictates everything. In fact, confusing the two is a great way to fail a medical board exam. Or, worse, miss a fatal injury in a patient. There is a concept in trauma physics called cavitation. This is the differentiator.
Cavitation. That sounds like something from engineering or submarine warfare.
It's exactly the same principle. Let's break it down. Think about a knife. If you get stabbed, the knife is a low-velocity object. It cuts exactly what it touches.
Right.
If the blade is 2 centimeters wide, it creates a path of destruction that is roughly 2 centimeters wide. It's linear, it's predictable, you can trace the line.
So if the knife misses your artery by a millimeter, you're basically safe.
Basically. A millimeter miss is a miss. You might have some local bleeding, but the structure right next to the knife track is usually fine.
Okay.
But a bullet, A bullet is a different beast entirely. It is a high-velocity projectile carrying massive amounts of kinetic energy. When it hits the body, it doesn't just drill a hole, it dumps that energy into the tissue.
Like a splash.
More like an explosion. As the bullet travels, it creates a shock wave. It pushes the tissue away from its path so violently that it creates a temporary cavity, a bubble inside you, that can be 10 or 20 times the size of the bullet itself.
No way.
Yes, and this cavity expands and then collapses in a fraction of a second.
So it's stretching and tearing things it didn't even directly touch?
Precisely. That millimeter miss we talked about, it doesn't exist with a gunshot. The shockwave rips the artery, shatters the near bone, or pulps the spleen even if the bullet physically passed next to it.
Wow.
That is why the guidelines have a specific exam burl. Gunshot wounds are significantly more destructive and unpredictable than stab wounds.
Which explains why, as we'll see later, doctors are so much quicker to operate on a gunshot victim than a stab victim. The physics just forces their hand.
It does. A stab wound is kind of what you see is what you get. A gunshot wound is an iceberg. The entry hole tells you absolutely nothing about the chaos underneath.
This leads us perfectly into the second pillar, the algorithm. The source material calls this the discipline of distraction. I love that phrase because it implies that paying attention to the wound is actually a mistake.
It is. It's a survival mechanism for the doctor as much as the patient. You have to train yourself, literally train your brain, to ignore what your eyes are drawn to.
Picture this. A patient comes in. They have a massive bleeding gash on their stomach. Maybe, and this is gross, but we have to go there, maybe there are intestines visible. Evisceration. My instinct, I think any normal human's instinct, is to look at the intestines and panic, or try to push them back in, or put a bandage on it.
And that instinct is the enemy. That is the trap. The guidelines are absolutely brutal about this. They essentially say, ignore the horror.
Because if you focus on the horror, you miss the thing that's actually going to kill them.
Right. You miss the silence. The protocol is strict. Management begins with the primary survey, the ABCDEs. It's a rigid checklist that you cannot deviate from, no matter how scary the belly looks.
We hear ABCDE in first aid courses, but walk us through it in a trauma bay where someone has been shot. I feel like the context changes everything.
The context changes the urgency, but the steps remain exactly the same. A is airway. It often comes with cervical spine protection to make sure their neck isn't broken.
Right.
It simply doesn't matter if their intestines are on the table. If their throat is closed or they aren't breathing, they will be dead in 3 minutes. You have to secure the tube.
So you fix the air first, then B.
B is breathing. Are the lungs inflating? Is there a hole in the chest that needs to be plugged? Then C is circulation. This is where we check the pulse, blood pressure, skin color. Are they pumping blood? Are they spraying blood from an artery? This is where we stop major hemorrhage.
Okay, so A, B, and C are the fundamentals of life.
Absolute fundamentals. Only after you have stabilized A, B, and C do you move to D for disability checking their brain function. Pupils, are they alert? And E for exposure.
Exposure.
Exposure means stripping them naked, cutting off every single piece of clothing and rolling them over.
Why is exposure so critical in that moment?
Because you need to find every single hole. You might be focused on the bullet hole in the stomach, but if you don't roll them over, you might miss the exit wound in the back or a second bullet hole in the armpit. You have to see everything.
There's a rule mentioned in the text here regarding the primary survey that I found really intense. It says, do not touch.
Yes. The specific instruction is, do not explore the wound during the primary survey.
Why? I mean, apart from it being gross, surely you want to know how deep it goes.
2 reasons. 1, safety. You don't know where that bullet went, or if there's a jagged bone fragment, you don't want to cut yourself. But 2, and this is way more important, you could make it worse.
How?
A clot might have formed that is temporarily plugging a severed artery.
A cork in the dam.
Exactly. The body is smart. It tries to save itself.
Yeah.
If you stick your finger in there to see how deep it is, you might dislodge that clot and cause a massive fatal hemorrhage right there on the table.
Oh, wow.
You can turn a stable situation into a complete catastrophe.
So, hands off. It's like, okay, analogy time. If your car is on fire and you also have a flat tire.
You don't change the tire while the engine block is melting.
Right.
You put out the fire. The airway and circulation issues are the fire. The hole in the belly is the flat tire. It needs fixing, but it can wait 5 minutes.
That is such a clear way to visualize it. So, the team has rushed in. They've ignored the guts for a moment. They've checked the airway. They've confirmed the heart is beating. Now they need to know, is this person crashing? This brings us to section 3, the red flags.
This is the black box problem. The abdomen is a closed container. Unless there's a gaping exit wound, we can't see the liver, we can't see the aorta. We have to infer what is happening inside based on the clues the body is giving us on the outside.
And the source material has a mantra here. Shock in penetrating trauma is surgical until proven otherwise.
That's the Goldie rule. Memorize it. If a guy has a hole in his belly and he is in shock, we don't wonder if maybe she's just dehydrated. We don't wonder if he's scared. We assume the hole severed a blood vessel and he is bleeding out internally.
We use the word shock a lot in casual conversation, like I was shocked by the news. But medically, shock is a very specific, very dangerous state, right?
Correct. It's not emotional. Medically, shock is inadequate tissue perfusion. It means your blood isn't delivering enough oxygen to your cells, and your cells are starting to die.
So what are the red flags? How does a doctor spot this from across the room?
The first is hypotension, low blood pressure. The pipes are running empty.
Yep.
The second is tachycardia, a racing heart rate. The heart is trying to compensate, pumping faster and faster to circulate the little blood that's left.
And then there's this term peritonitis. I see this word all over the guidelines. It seems really important.
Peritonitis is a huge red flag. It's inflammation of the peritoneum, that lining we talked about earlier. If bile, stomach acid, or poop leaks out of the gut and touches the peritoneum, it causes intense chemical irritation. It burns.
How does the patient react to that? What does it look like?
The muscles of the abdominal wall seize up to protect the organs. The belly gets rock hard. We call it board-like rigidity. And it's excruciating. If you just tap the bed, the patient screams.
So that's an unmistakable sign.
Unmistakable. If you see peritonitis, that's a red flag that screams, "Take me to the operating room."
And obviously the fourth flag is ongoing active bleeding. If blood is pouring out, that's a clue.
Exactly. These signs, hypotension, tachycardia, peritonitis, active bleeding, are absolute. They tell you the body is losing the fight to maintain homeostasis.
So we have the physics, we have the algorithm, and we know the red flags. Now we arrive at the most critical moment in the trauma bay. Section 4. The fork in the road.
The decision. This is where the doctor really earns their paycheck.
On one side we have go, immediate surgery, laparotomy. On the other side we have wait. And this is the part that I think will surprise a lot of listeners. You can get stabbed, go to the ER, and the doctor might decide to not operate.
It happens all the time. In fact, for stab wounds, it's becoming the standard of care in many places. It's called selective non-operative management, or SM.
Okay, hold on. Selective non-operative management. That sounds very bureaucratic for, we're just going to watch you bleed. How is that safe?
It sounds completely counterintuitive, doesn't it? But think about it. Surgery is not benign. Surgery is trauma. We have to anesthetize you, which drops your blood pressure. We have to slice through your abdominal muscles, which takes months to heal and can cause hernias later. We expose you to hospital infections.
So if you don't need the surgery itself becomes the risk.
Exactly. If the stab wound only went into a piece of fat or nicked the liver slightly, which often stops bleeding on its own, opening you up just to look around creates more damage than the knife did.
The cure becomes worse than the disease.
That's it.
That's a wild concept. But, and this is a massive but, the criteria for choosing to wait and watch must be incredibly strict. You don't just send them home with a Band-Aid.
No, absolutely not. The criteria are rigid. Rule number 1, stability. If the patient has low blood pressure or a racing heart, S&OM is off the table, period. They are bleeding somewhere and we have to go find it.
Okay.
Rule number 2, no peritonitis. If their belly is rigid, it means there's a leak. We have to sew it up.
And there's a third rule regarding the patient's mental state, right? This one seemed really interesting to me.
Yes. You need a reliable clinical examination. This is a major trap for young doctors. If the patient is drunk, high on drugs, has a brain injury, or is unconscious, you cannot use the wait and watch approach.
Because they can't tell you how they feel. They can't report pain.
Exactly. The whole point of watching is that we ask, does it hurt more now than it did an hour ago? If the patient is passed out or too high to feel pain, the appendix could burst or the bowel could rot, and they wouldn't flinch.
So you can't trust their exam.
You can't. In those cases, we can't take the risk. We usually have to investigate surgically because we've lost our best monitoring tool.
Yeah.
The patient's own sensation.
And does the weapon matter here? Can you wait and watch a gunshot wound?
That is highly controversial, and generally the answer is be very, very careful. The guidelines emphasize that S-NOM is primarily for stab wounds.
Because of the cavitation?
Because of that cavitation we discussed, the unpredictability. Most gunshot wounds that penetrate the belly end up in surgery. There is a specific exam trap noted in the source material. Never try SNOM on an unstable gunshot victim. That's a death sentence.
Okay, so if you're stable, alert, and it's a stab wound, you get monitored. What does that monitoring actually look like? Is it just a nurse poking your head in every few hours?
No, it's active surveillance. It's intense. It's serial abdominal exams. A senior doctor comes by every 30 to 60 minutes and physically pushes on the belly. They are looking for subtle changes. Is the softness turning into hardness? Is the heart rate creeping up? It requires a high-resource environment.
So if you're in a small rural clinic with one doctor,
You probably just ship them out or operate, because you don't have the manpower to watch them like a hawk for 24 hours. S&OM is a luxury of a fully staffed hospital.
now surely technology plays a role here. We live in the age of advanced imaging. Section 5 covers the tools of the trade. When do we scan? Why don't we just scan everyone?
This is one of the most misunderstood parts of trauma care, even by medical students. The logic of imaging depends entirely on one word: stability.
It keeps coming back to that. Stability is the gatekeeper for everything.
It is. If the patient is stable, like our stab victim who was chatting with the nurses, blood pressure is fine. The investigation of choice is a CT scan with contrast.
Why contrast? Is that the dye they make you drink or inject?
Yes, either drink it or inject it into your veins. The contrast lights up the organs and blood vessels on the X-ray. It allows us to build a 3D map of the track. We can see exactly where the knife went, if the liver is nicked, or if the bowel is leaking fluid. It gives us the confidence to say, okay, we can keep watching.
Okay, that makes sense. But what if they are unstable? What if they're crashing? My intuition says, quick, get a scan so we know what's wrong.
And your intuition would be wrong. There is absolutely no role for a CT scan in an unstable patient.
None. Even to help the surgeon know where to cut.
None. In the trauma world, we have a dark nickname for the CT scanner in these moments. The donut of death.
The donut of death. That is evocative and terrifying. Why is it called that?
It's dark humor, but it's based on logistics.
Yeah.
Think about where a CT scanner is in a hospital. It's rarely in the ER bay itself. It's down the hall, maybe in the basement.
Right.
You have to unhook the patient from the monitors, load them onto a transport gurney, wheel them down the hall, transfer them to the scanner table, do the scan.
All while they're bleeding internally.
Exactly. It's a 15 or 20-minute round trip where the patient is poorly monitored and inaccessible. An unstable patient doesn't have 20 minutes. If you take an unstable patient to the donut of death, they will likely code and die inside that machine. They need a surgeon, not a radiologist. They need the bleeding stopped now.
So if they're crashing, you skip the pictures and go straight to the theater.
You bypass everything. You roll straight to the OR. We might use a fast scan, which is a little handheld ultrasound we can do at the bedside in 2 minutes just to check for free fluid. But generally, instability equals operation. Time is the enemy.
Let's say we were in the operating room, or at least evaluating the damage. Section 6 maps out the commonly injured organs. If someone gets poked in the belly, what's likely to get hit?
It's a game of probability. Think about packing a suitcase. What takes up the most room?
In the belly, I guess. The intestines.
Right. The small intestine, it's roughly 20 feet of coiled tube packed into your abdomen. Statistically, if you stick something sharp into the belly, you are probably going to hit a loop of the small bowel.
It's basically just wall-to-wall intestine in there.
Pretty much. So the small intestine is victim number 1. Following that, you have the colon, the liver, and the spleen.
The notes make a really interesting comparison here to car crashes.
Yes. In blunt trauma like hitting a steering wheel, the solid organs break. The liver and spleen are like heavy, wet sponges. If you shake them hard, they crack. But the intestines are hollow tubes. They usually float away from the impact.
But in penetrating trauma,
In penetrating trauma stabs and bullets, the tubes, what we call hollow viscous, are the main victims because they can't get out of the way of the blade. They are pinned in place.
the source material also highlights some special scenarios or traps regarding where the wound is located.
Yes, location tells a story. For example, if there is a wound in the epigastrium, that's the upper middle part of your belly, right below the rib cage, so sort of the solar plexus area,
Got it.
you have to be highly suspicious of the stomach or the pancreas.
And the pancreas is bad news, right? I've heard that's a difficult organ.
The pancreas is a nightmare to fix. It's located deep in the back, behind the stomach. And remember, the pancreas produces enzymes designed to digest steak. If the pancreas is injured and leaks those enzymes,
They start digesting.
they start digesting you, literally. It causes a chemical burn from the inside out. It's incredibly difficult to manage.
Yikes. That is a horrifying image. What about wounds on the back?
Flank or back wounds are tricky because they involve the retroperitoneum.
Retroperitoneum. That means behind the peritoneum.
Correct. There is a space behind that abdominal sac where your kidneys and major blood vessels live. Injuries there are harder to diagnose because the bleeding is contained in the thick muscles of the back. It doesn't always show up as a rigid belly in the front. It's a blind spot.
So you have to be extra careful.
Extra vigilant there, yes.
And we mentioned evisceration earlier, intestines coming out. The source makes a nuanced point here that I found surprising. It says, evisceration does not always mean perforation.
Right. Just because a loop of bowel is hanging out, it doesn't mean the bowel itself has a hole in it. It just means the abdominal wall has failed. The intestine might be perfectly intact, just in the wrong place.
But I assume you operate anyway. You don't just, try to push it back in.
Oh, absolutely. You can't just push it back in like stuffing a turkey. You have to take them to surgery, wash the bowel off because it touched your clothes, or the floor check every inch of it for holes, and then put it back in a sterile environment. But strictly speaking, the presence of bowel outside the body doesn't guarantee the bowel itself is perforated.
We're coming to the final section of this deep dive, core principles and mental models. If our listeners take away one philosophical rule from this, what should it be?
The source material boils it down to one sentence that every trauma surgeon lives by. Physiology decides surgery, not the size of the wound.
Physiology decides surgery. Let's unpack that one last time.
It means you could have a massive, ugly, jagged gash across your belly. It looks like a horror movie. But if your blood pressure is normal, your heart rate is steady, and there's no internal leak, you might not need an operation on your organs.
You just need stitches.
You just need stitches for the skin. The wound looks bad, but the physiology is good.
And the flip side.
You could have a tiny puncture from an ice pick, barely a red dot on your skin. But if your heart rate is 140 and your pressure is dropping, you are going to the OR immediately to find the artery that ice pick severed. We treat the patient's condition, not the aesthetic of the hole.
That is such a critical shift in thinking. It's about the system, not the symptom.
Precisely. And that leads to the common pitfalls, the traps that trip up even experienced doctors.
What's the biggest trap?
The normal exam. A patient comes in, they look fine, they say they feel fine, they're chatting, texting their phone. The doctor thinks, oh, bullet dodged, literally.
Right.
But adrenaline is a powerful drug. It masks pain. Or the bleeding is venous, slow, and oozing.
So they might crash an hour later.
Exactly. A normal initial exam does not exclude injury. That's why we do serial exams. You have to be paranoid.
And another trap mentioned is antibiotics.
The antibiotic myth. Antibiotics are great. They prevent infection, but they do not fix a hole in the gut. If bowel contents are leaking into your body, no amount of penicillin is going to fix that. You need a surgeon, to sew the hole shut. Antibiotics are just the insurance policy. They aren't the repair.
This has been a fascinating tour through the mind of a trauma surgeon. It's so much more than just cut and sew. It's a constant evaluation of risk, physics, and physiology.
It is. It's about maintaining discipline when everything around you is chaotic.
So let's wrap this up with our rugged recap. The 10-point cheat sheet for penetrating abdominal trauma. Take us through it.
All right, let's do it. 1. Penetrating injury means a breach of the abdominal wall, the peritoneum.
Got it. 2.
2. Gunshot wounds are way more destructive than stab wounds because of cavitation.
The shockwave.
The shockwave. 3. The ABCDE protocol is law. Primary survey first. 4. Shock is surgical until proven otherwise. Hypotension means they're bleeding.
5.
5. Peritonitis, a rigid belly mandates surgery.
Number 6.
6. Gunshots that cross the abdomen are usually a go signal for the OR.
7.
7. CT scans are only for stable patients. Unstable patients avoid the donut of death.
Number 8.
8. The small intestine is the most commonly injured organ, just by real estate.
9.
9. You can sometimes watch and wait with S&OM, but mostly for stable stab wounds in reliable patients.
And finally, under 10.
And 10. Physiology is king. Treat the vitals, not just the whole.
Brilliant. And as we close out this deep dive, I want to leave the listener with a thought. We've talked a lot about the discipline of the doctors, how they have to ignore the screaming, the blood, and the visual horror of a wound to focus on the quiet, invisible things like the airway and blood pressure.
It's the ultimate exercise in prioritization under pressure.
Exactly. And I think that applies outside the ER too. In our own high-pressure moments at work, in a crisis. Are we fixing the visible wound just because it's right there and it looks scary? Or are we checking the vitals of the situation first? Are we putting out the fire before we try to change the tire?
That's the question. Sometimes the most important problem is the one you can't see yet.
Thanks for joining us on the deep dive. Stay curious, stay safe, and we'll see you next time.